Mobility Part 2, Introduction to Nursing Concepts. We practice with a question on prevention. When we look at the stem of this question, the client has been placed in skeletal traction and will be immobilized for an extended period. The nurse recognizes that there is a need to prevent respiratory complications by. So what the stem is really asking is extended period, meaning long-term immobilization, and we're looking specifically at respiratory complications. The answer is number 4, encouraging deep breathing and coughing every hour. As we think about the critical thinking, focus on auscultation in the dependent lung fields because that's where the pulmonary secretions tend to collect in those lower regions. As we look at our metabolic rate, we know that with immobility, the basic metabolic rate decreases. The metabolism of fats, carbs, and proteins change. The calcium reabsorption, that leads to osteoporosis. That's why weight-bearing exercise builds stronger bones. Immobilized clients often have that increased basal metabolic rate from a fever and wound healing, and so you may see it being elevated or decreased depending on what's going on with that patient. What can you as a nurse do? Lots of things we can do. We can look at encouraging fluids, preventing dehydration, range of motion. We can look at the patient's lab values. We can encourage the diet. We can encourage the patient to be doing as much as they can for themselves and choosing a healthy diet. As we look at fluid and electrolytes specifically, we know that with dehydration, that increased urine excretion from changes in that increased blood flow to the kidneys and expanding that circulating blood volume. With a condition called hypercalcemia, calcium reabsorption loss from the bones, because they're immobile, causing the release of excessive calcium, and what we see oftentimes is the kidneys may not respond appropriately. With dehydration, we are looking at what are the effects on the body, and as we get to class, we're going to be looking at a mind map, and we're going to be sharing and identifying what are the effects of dehydration on all parts of the body. With the skin, we've talked about the integumentary, the skin breakdown. With constipation, kidney stones, blood clots or thrombus formation, respiratory infections, we think of very thick respiratory secretions that we talked about in the oxygenation unit. Urinary tract infections are a result from dehydration. Different patients can be at risk for different reasons. Your patient with dementia, they oftentimes forget to drink. So as a nurse, we would offer fluids more often. For a patient that's had a stroke, we may have to thicken their liquids because they have dysphagia, and it may take longer for them to consume enough calories and fluid to maintain their hydration status. For a patient that's very dyspneic or short of breath, that difficulty breathing often takes precedence over eating, and their food and fluid intake is decreased as a result of COPD and our other chronic respiratory conditions. A patient on chemo and radiation will oftentimes experience nausea and vomiting, and that can lead to dehydration. We need to pre-medicate with the antiemetics and try to get them to drink small sips of things that they're able to tolerate. If not, we may have to replace with IV fluids. So lots of reasons we can have patients that are dehydrated, and as a nurse we need to anticipate that, and we need to prevent the dehydration from happening. GI changes, we know constipation can be from a lack of activity and also hypercalcemia. As we look at word mapping or following our track down, anorexia causes decreased fluid intake. That causes constipation, that causes fecal impaction, that can be distension, and a condition called peritonitis of the abdomen can happen. As we look at a patient with colon cancer or having a colectomy, we know that many of our patients feel very fatigued and nauseated. They don't have any energy. They have what we call malaise. And the longer the treatments go on, sometimes the worse that this can get. So the effects of chemo and radiation on mobility and dehydration can be very profound. When we look at what is cachexia, that is a term that is for wasting of the muscle, wasting of the body tissue as a result of that immobility. And the immobility for these cancer patients sometimes is compared to the post-op patient that has that. As we look at cardiovascular changes, very significant. Our orthostatic hypotension, or when they stand they get dizzy, they can oftentimes have a blood clot or a thrombus, and that thrombus can break loose and become the embolus that travels through the body. We worry about that embolus traveling to the brain and the lungs, and if in the lungs it would be called a pulmonary embolus or a PE, and the edema. When we look at this slide, I would take special note of that, because 3 factors that cause some cardiovascular changes probably will show up on the test. Damage to that vessel wall. With the damage to that wall, it alters in the blood flow. It doesn't have that nice smooth vessel to flow through. It has turbulence because there's damage. And with that alteration in blood constituent, or how thick the blood is, all of those things, those 3 factors, are known together or collectively as Virchow's triad. Know that. For the client in a full body or spica cast, the nurse remains alert to possible changes in that cardiovascular system. The nurse may find that the client has, and the answer is number 2, tachycardia. The body is working harder, cardiovascular, as a result of immobility. With the cardiovascular changes, then, we want to try to reduce orthostatic hypotension. If your patient hasn't been up for a week because of an injury, get them up very slowly. Try to reduce that work of the cardiac system, avoid any straining when they're up to the toilet, that Valsalva's maneuver that we've talked about. Use stool softeners as needed to prevent that straining. In bed, if they're dehydrated and not eating like usual and taking narcotics, we know that constipation is going to be a problem. And then preventing thrombus formation, and we will spend a lot more time talking about that, because we look at risk factors like patients that are high risk, or the ones that are immobile, that are dehydrated. So things like SCDs, sequential compression devices, early ambulation, anticoagulants like your heparin and Lovenox, range of motion and passive range of motion are all things that we can do with that cardiovascular system. In the musculoskeletal system, then, we know that those muscles and bones get weaker the longer we lay. And as we look at our muscular changes, the one on here that probably is the most concerning to me is that joint contracture. We want to prevent that with some range of motion, if at all possible. Foot drop is kind of a result, or a contracture to those lower feet that we can see. With loss of strength and endurance, your patients are weak. They aren't able to walk very far, and we have to slowly build them back up to a state where they're able to be much more independent and safe on their feet as well. As we look at who's most at risk, we look at the people on prolonged bed rest. They're going to have bone demineralization, or those bones that are breaking down. Your postmenopausal women, those that are taking steroids for inflammatory conditions, and then those that have high blood or urine calcium levels as well. So we have several patients that would be at risk. In our picture here, we see a man that has traction. You see the trapeze above him, but then he also has the traction above and below the knee, and high risk for blood clots, because where that traction is pulling that leg up, you're not getting good blood flow. It's obstructing the blood flow in those areas. In the urinary system, we know urinary tract infections and stones or renal calculi are a result of urinary stasis. If I lay in bed, I'm not drinking, and I am simply rolling to get on a bedpan, I have stasis of urine that can lead to other more serious conditions. As we look at our word mapping for this one, immobility causes increased calcium to leave the bones and come to the circulation. That decreased calcium to the bones causes a condition called hypercalcemia, or more blood in the, or more calcium in that blood. So if possible, get them up to the commode to void. Try to stimulate gravity drainage, encourage them to drink fluids, keep that urine less concentrated, and then have them do as many self-care activities that they can on their own. As we think about questions, the patient has limited mobility upon discharge. What instruction would you emphasize to the family to help prevent urinary stasis and renal calculi? So prevention is important. And it's going to be encouraging oral intake with water and juices. That's something upon discharge families can definitely be in charge of. For the integumentary system, we want to assess many things. As the slide says, the longer the pressure is applied, the longer the period of ischemia and the greater the risk of skin breakdown. And we covered most of this in the tissue integrity unit. As we look at mobility, other diagnosis that we have, your patients that have hip fractures, that have had open reduction, internal fixation surgery where they've gone in and repaired that hip. They haven't replaced it, they've just repaired it. We know that positioning is going to be something very important. Looking at our patient that had surgery to the hip, we would not want those legs to come together. We want to abduct those legs to keep that hip in its new position. Ambulate with physical therapy. Many times they will be using a walker and partial weight bearing as they get going. Keep them safe by using all of the safety techniques, the gait belt, plenty of help, getting them up slowly. And our nursing diagnosis related to mobility is probably impaired physical mobility. Impaired skin integrity would relate to this very closely. And then acute pain would also be another nursing diagnosis that we might put with a patient that has had hip surgery. In looking at your patient with a stroke, they have one-sided weakness or hemiplegia, right-sided weakness. Our positioning for the patient with a stroke then is going to be with a lot of pillows, especially that arm that has the hemiparesis. We want to use a lot of emotional support after a stroke so they have that ability or that encouragement to want to get up and do as much for themselves, because getting depressed is often seen after a stroke. Tipping or falling is a safety concern, because now that they've had a stroke and one side is weak, they're going to be leaning. Their center of balance or their center of gravity is now off. And we're going to always use a gait belt, walkers, supportive shoes, and only ambulate patients when they're well rested and ready to help you so that they don't get very weak and get depressed because they can't even make it out to the hallway. Nursing diagnosis that fit with the patient with a stroke are things like impaired physical mobility, activity intolerance, disturbed body image, risk for injury, impaired physical mobility, and again, impaired skin integrity would be a nursing diagnosis that might fit with your patient that's had the stroke. Your patient with COPD oftentimes will have problems with impaired physical mobility and activity intolerance. We've covered this in the oxygenation unit. Positioning, remember, is high Fowler's orthopnea position, sitting up more to encourage that chest expansion. Ambulation is with oxygen and they become very dyspneic, and so we have to check O2 sats before, during, and after ambulation to see if we have to give them more oxygen when they're ambulating, when they become short of breath. Safety because of the weakness that they have, and then again we transfer using those safety principles. Your patient with colon cancer, having had a colectomy, chemotherapy and radiation, lots of mobility issues with these patients. We know that they're going to be weak. Many of them will have low red blood cells, predisposing them to things like anemia, and they're pale and tired, and as a result, safety and mobility are impaired. They don't have the ability to get up and walk very far because of that. And before a blood transfusion, we probably want to make sure that they have oxygen on, because all of those red blood cells that are missing with the anemia aren't able to oxygenate the tissues. And so we have a condition called hypoxemia. Again, our mobility is important, skin integrity, acute pain, body image with the colectomy, lots of nursing diagnoses that are going to fit with your patient with cancer, especially if they have hair loss and other physical changes noted. And as we look at a patient with paraplegia, we know that they have loss of sensation. As we discussed in the tissue and wound care unit, many of them are high risk for skin breakdown and decubitus ulcers, especially sitting in a wheelchair. They need to be repositioned every 15 minutes to take the weight of that off of their coccyx and buttock area, because that's where all the pressure is. We will be completing assessment in part 3.